The thing that I'm most pleased to tell you about, which is that normally when you introduce a technology, as you know, it's very hard to get anybody to pay for it. Why do we need the new thing? Are all things fine? You know, and of course, in the era of COVID and healthcare and economics, everybody is buckling down. But the FDA gave these single-use devices as a category breakthrough technology status, which then led CMS to provide a pass-through payment.
Public health. It's on everyone's mind these days, from hand washing to emerging pathogens. Welcome to Transmission Control, an infection prevention podcast focused on your appetite for trailblazing thought, discussion, and innovations that will help you make informed decisions. Each episode, we speak with public health experts and safety champions from across the globe as they share their experiences, passion, and opinions. From investigative journalism to medical publications, we tackle real-world barriers to halting the spread of disease. Whether you are tuning in for education, inspiration, or to hear the stories that need to be told, thank you for joining us. And now, get ready to blast off with your weekly injection of insight on transmission control.
This week on Transmission Control, we speak with Dr. Raman Muthusamy, professor of clinical medicine at the David Geffen School of Medicine at UCLA, and he's also the medical director of endoscopy for the UCLA Health System. Dr. Muthusamy is recognized as a leader in advanced endoscopic procedures. His clinical research interests focus on the evaluation of existing and new endoscopic technologies for the diagnosis and treatment of digestive disorders. They include endoscopic ablative techniques for Barrett's esophagus with dysplasia and early esophageal adenocarcinoma. Clinical applications of EUS with a particular focus on EUS-guided tissue acquisition, ERCP with a particular interest in cholangioscopy, stent placement, and device reprocessing, and endoscopic mucosal resection. Dr. Muthusamy has also participated in numerous studies involving the development of quality metrics in endoscopy and methods to improve the efficiency of and safety of endoscopy care, including leading a multi-center evaluation of the first single-use duodenoscope. Prior to his recruitment to UCLA in 2011, he was a faculty member at the University of California Irvine Medical Center. In addition to his extensive clinical work in interventional endoscopy there, he also served as the director of the GI Fellowship Program at UC Irvine. He has also previously served as director of endoscopic ultrasound at the University of California, San Francisco. Dr. Muthusamy completed his undergraduate work at Stanford University with distinction and went to medical school at the University of Washington School of Medicine, where he graduated with honors. His residency was undertaken at Duke University Medical Center, where he served as assistant chief resident and traveled abroad to study evidence-based medicine under Dr. David Sackett at Oxford University. He completed his fellowship in gastroenterology at the University of California, San Francisco, before undertaking his advanced endoscopy fellowship at the University of California, Irvine, which he completed in 2001. Dr. Muthusamy is board certified in gastroenterology and has been frequently recognized by Best Doctors since 2011. He is a past president of the Orange County GI Society and a counselor and the current president of the Southern California Society of Gastroenterology. He is a fellow at the American College of Gastroenterology, ACG, the American Society of Gastrointestinal Endoscopy, ACGE, and the American Gastroenterology Association, AGA. He serves as one of two ACG governors for Southern California and is a former member of the ACG Research and Public Relations Committee and currently serves on the Educational Affairs Committee for the ACG, as well as an associate editor for the American Journal of Gastroenterology. He has previously served as co-director of the ASGE's Improving Quality and Safety in Your Endoscopy Unit course and serves on the ASGE Quality Assurance in Endoscopy Committee. He has also previously served on the AGA's Research Awards panel and is the immediate past chair of the AGA's Center for GI Innovation and Technology. So, Larry, to say that Dr. Muthusamy is highly passionate and involved in this industry would be a gross understatement. And so it's no surprise his involvement with the new Multisociety Guidelines, which is why we're having him on the show to talk to us today.
Yeah, I've read a number of his papers. he's really a rising star, if not having already achieved the top. He may not be rising anymore. He may be the star. And I'm really looking forward to hearing what he has to say about the Multisociety Guideline, and particularly the pragmatism that can come out of it as to how the practitioners can see the guideline in ink, but then hear what Dr. Raman has to say about it and how they then can translate his advice and his good counsel and implement it into their own GI endoscopy units so that patients can be assured that they're getting the safest care possible. And Dr. Raman is really a leading factor in, as you likely will hear from his compassion and passion, where he will really speak on our behalf and do everything possible that he can in terms of his research and in terms of his practice to make us as healthy as we can be.
All right. Well, this is going to be a good one. Stay tuned. We'll be right back with Dr. Raman Muthusamy.
Brought to you by 17 Studios. Let's get into it. This is Transmission Control.
Joining us now is Dr. Raman Muthusamy, Professor of Clinical Medicine at the David Geffen School of Medicine at UCLA and the Medical Director of Endoscopy for the UCLA Health System. And Raman, this is a pretty big interview for us. We're very excited to have you on the show today to talk about the new Multisociety Guidelines. So I just can't thank you enough for joining us.
Great. Well, thank you, Justin and Larry, for inviting me, and I look forward to a great conversation today.
Why don't we start with I'd say, let's get an understanding for everybody who's listening, because we have a pretty wide audience and maybe not everybody understands the background on the Multisociety Guidelines. So can you talk about them from a historical perspective and then also tell us what's maybe some key points from the new guidelines?
Yeah, thank you. So the Multisociety Guidelines have, at least over the last several editions, Justin, been primarily coordinated by the American Society for Gastrointestinal Endoscopy. And they've basically been updated approximately every 5 years or so. The last update we had was in 2016, right after a lot of the issues with duodenoscopes came out. And then this is sort of the 2020 version, which just got published in 21. And so we've tried to sort of tackle the hot topics at the time. But one of the things that we did, you said, well, what's different about 2020 compared to 16? I think 2016 really tried to address a lot of the issues that we were seeing with regards to duodenoscopes and sort of early sort of best statements. We tried to tackle from an evidence-based sort of grade methodology standpoint 4 questions on this document, some of which there wasn't enough evidence to really answer. But one was double HLD compared to standard HLD, and is there a benefit? The second was same for ethylene oxide sterilization, and what is the role? The third was the issue of how long can a scope be stored and reused safely without need for reprocessing? The final question was, what is the best way to do surveillance of endoscopes to determine if they are in fact clean? Is it culture? Is it ATP? Is it something else? So those were the 4 big ticket items we tried to do. And then there were, in addition to that, 18 sort of additional topics that were addressed, in terms of flow of scopes, how do you store cabinets, a little bit more granular details about the whole process. And we did also have, as readers of the document will see, a huge table of unanswered questions. And so obviously, I think in the infancy of science in this very important area, and I think we have more questions than answers at this point, as I feel our conversation will probably highlight today.
I feel like the more answers you get, it's just going to be one of those things where there's more questions. And even these scopes, they're some of the most complex medical devices in the industry. So there's a whole other host of considerations there too. But one thing you said about the new Multisociety Guidelines was trying to address how long a scope can be stored before it's used. And I just know there's been different bodies that have had different recommendations. And I know that many facilities basically were told by the surveying organizations, as long as you pick one and you stick to it, you're in good shape. But that, I think, was still somewhat unsettling for people because as healthcare practitioners, you want to do the right thing. And so I'm really glad that that was addressed. And I also want to just go back. You mentioned two different forms of high-level disinfection. Can you just describe the two of those for anybody who's not really knowledgeable around this form of sterilization or disinfection, I should say, in the GI world?
Yeah, so, I'll just take a step back. In 2015, after, all the reports of issues with the duodenoscopes, the FDA basically said, hey, you should probably do enhanced reprocessing of these devices, and we're going to give you 4 options, right? One was sterilization ethylene oxide. One was double HLD, which by its purest definition involves both the manual sort of cleaning of the scope, putting it in through typically an automated endoscope reprocessor, running it through that, and then redoing both steps, both the manual and the reprocessor. Some people just kind of run it through the washer twice and they don't do the manual. That's technically not precise, but the true double HLD should do both. The third option was liquid chemical sterilization, sort of the peracetic acid typically. And then the last was do your HLD, but then do a culture and quarantine. Take the scopes, sample them, and that could be at some interval. It didn't have to be necessarily at every case. Maybe it's once a week. The guidance was that it should be it's certainly not longer than 60 days, which seems rather long. But those were the 4 options. But just to go back, I know your audience is quite sophisticated, but the HLD process is as soon as the scope comes out, obviously you run an enzymatic, you do a bedside pre-clean, you do a leak test. You then sort of do a detailed manual cleaning, which is a critical step. And for duodenoscopes takes, even in expert hands, 20 minutes. I often joke that cleaning the scope is as complex and longer in some cases than the procedure. And it's a lot of steps. And then you run it through the AER typically. And then it's important that you properly dry and store the device, of course, to prevent the risk for recontamination. It's really the whole cycle that's present. And like I said, those were the main options right now.
I'll tell you, we've got an upcoming podcast to talk about drying just on its own topic, and I appreciate that. So one of the things you just described was ETO, which is a method of sterilization, but then the other methods being high-level disinfection. So that's definitely one of the things that we wanted to talk to you about today is the sort of this debate that's going on in the industry of sterilization versus high-level disinfection. So do you have any initial thoughts on that before we dive in?
Yeah, I think obviously the margin of protection that is afforded by sterilization is certainly greater and covers some of those bacterial spores and prions and things that may not be. I do want to mention, I think the key issues that we have, of course, are that the way that a lot of things are sterilized in the OR will not work for endoscopes, unfortunately, because endoscopes are destroyed by high temperature, right? So we need a low temperature sterilization option. And the options that we currently have, or I should say option, because it's really ethylene oxide to be precise right now, is that it's not widely available. It's a toxic chemical. There's risks to the reprocessors and so on and so forth. And so while it's certainly attractive, the devil's always in the details and in the practicality and some of the other issues. And we can talk a little bit more. I mean, certainly there's some data that we've seen over the past 5 years that a good process improvement program installed at many institutions have shown improvements in our overall sort of the quality of our reprocessing. And if you take a look at some of the studies that are being done, that you'll see that there's a significant improvement in sort of contamination rates, at least as measured by culture and ATP levels, if you're going to use those sorts of things.
Just as a side note there, the Multisociety Guidelines going back to 2016, I think was coinciding with the accountable care coming in and how that if patients are readmitted with an infection after being at the hospital, that all of a sudden we're cost shifting and that responsibility is going to the hospital. There was a growing focus on reprocessing, the cleaning aspects, and then obviously high-level disinfection or sterilization. But I think for the most part, awareness of that area of healthcare was very low, and the awareness is certainly on the rise. Larry, I don't know if you want to jump in here too, but that happens to be an area of passion of mine, is really getting the word out about cleaning and even the folks that we have doing those jobs and the types of training and education we provide.
Right, and very valid points, and thank you for all that very comprehensive information that you gave us. One of the topics that I've researched, I guess, for about the 2 last decades are two things that fall into this. One is that semi-critical devices are ideally to be sterilized, but when not feasible, we high-level disinfect them. And the second point is the sensitivity to when a guideline makes a recommendation or says you should do something or you may consider something or it's strongly encouraged. The listener hears different things there. So with this whole debate of semi-critical versus critical, with duodenoscopes being semi-critical, the guidelines really still have recommended all along sterilization without necessarily a reclassification. They have said sterilize when feasible, and the FDA has released some alerts within the last couple of years, I guess beginning in 2015, saying we prefer you sterilize these devices. So sterilization of duodenoscopes is still consistent with a semi-critical classification. It's not requiring that we move to the critical classification per se, which of course then it's not a recommendation to sterilize, it's a requirement to sterilize. So might you talk a little bit about how the guideline handled the situation where it seems they kind of took that stance and advocated high-level disinfection for these semi-critical devices in lieu of reclassifying them, which I think is actually probably appropriate. There's some other papers that I've read where authors, Humphreys et al., for example, made very strong argument that we really should reclassify these devices. So where do you think you are now? Can we leave them where they are but recommend sterilization when feasible? Or do you think we really should move to sterilization to the critical classification, and then that wouldn't recommend sterilization, that would require sterilization? I'm very interested in your thoughts on that.
Larry, you hit very important points. I think you hit one of the key issues, which is feasibility, right? And I'll tell you some of our own challenges because we do sterilize our duodenoscopes, and I can tell you some of the challenges that we've had over the past several years. So I think that the idea is again, this whole issue, are duodenoscopes critical or are they semi-critical? One of the issues that you sort of say is if you take a look at the two areas in the body that probably have the greatest bacterial counts are the two areas that we introduce our endoscopes into, right? Your anus and your mouth, right? And so this sort of argument sort of goes, well, if you sterilize the scope, won't it be unsterile as soon as it hits the mouth and the oral pharynx? And now you've got that sort of stuff. It's the same sort of rationale that you can sort of use when you say, well, if you're going to use a sterile catheter to go into the bile duct, right? But if you put it through you're as good as your weakest link, so to speak, you know? So to some degree, the feeling is that even if you sterilize this, you'd still be putting it through this, and what would be the benefit if the tip had these sorts of issues? So,
and if I can interrupt very quickly, that's consistent with your discussion about the use, which we will get to soon, about the use of tap water over sterile water for irrigation. The argument is we have immunosuppressed patients. There's some data that suggests sterile water is ideal. The guideline did go with sterile water as being ideal. And with this better practice, we're introducing sterile water into an unsterile colon for irrigation of the mucosa. So I'm sorry to interrupt, but I just wanted to mention, consistent with your line of reasoning, there is this argument about putting a sterile instrument into a non-sterile organ, if you will. But of course, the focus is not so much on endogenous translocation. Of course, that's an issue. We're looking more about how to prevent transmission of CRE and related superbugs. So that's an important point. Can you also discuss that and clarify that a little bit? The difference between infecting yourself with your own bacteria versus infecting yourself with a deadly superbug from an unrelated carrier somewhere else in the hospital.
Yeah, and certainly, particularly procedures like ERCP, we know that, there's going to be, for example, bacterial translocation. If we're putting a stent in an infected system, we're injecting contrast under pressure into the liver. You have the risk of bacterial translocation during those things. And again, that translocation is, I'm taking the bacteria that was present in your GI tract or biliary tree and putting it into your bloodstream, and you may get temporarily sick. And Larry, what you're describing is if I'm introducing a new bacteria into you that actually came from somebody else, whether it's drug resistant or not, obviously the drug resistant ones are the ones we can track because of the sophisticated molecular, but there's probably some that are non-trackable that, you never know they respond to antibiotics, and you don't know, as you were referring to, Larry, if that was endogenous or was it exogenous. It's just, but those people tend to get better. Or we can talk about the whole issue of even if you scope someone with a contaminated device, many of those people, nothing happens to them. And so the question is, why do X% get infection and why don't? And I've done some research into that question, at least based on our outbreak. But going back, I think, to the issue of this sterilization, first I think we were talking about duodenoscope, semi-critical versus critical. And I think I kind of gave a little bit of the rationale as to why we stayed with semi-critical. But then, as you mentioned, Larry, the second part of that is that the FDA does say that you should still try to do sterilization of those devices. And that's exactly correct. That's exactly what they've said. But again, it goes down to practicality. So if you're going to sterilize right now, what are your options? I guess if you do liquid chemical sterilization, that's generally not considered it because the water isn't necessarily sterile that comes back at the end. So there's people have said, well, the last step, you're only good as your weakest link, and your last step is non-sterile water. So therefore, you sort of undo it. And if you use ethylene oxide, that's been increasingly regulated and banned. So it depends on your state. Some states don't allow it. I know, for example, some institutions in the early days, right after this duodenoscope issue came up, they were using sterilization and they were shipping out of state. I know institutions that were shipping 3, 4, 5 states away. So you would get scoped in one state, you would have to ship to another state, you'd get it back. And so you can imagine, in addition, there's a certain reprocessing time with sterilization. You've got to vent. For example, many states, I know Illinois has put restrictions on ethylene oxide. In California, you can only do ethylene oxide in non-residential areas, so you can't do it at the hospital. We kind of send ours down to the shipyards, actually, to get it done. So, and then now, I'll give you an example, guys. We used to be able to get sterilization done daily. We use a major sterilizer, a well-known company. They would be able to do it daily. But as of earlier this year, they've informed us that due to some new regulations, they're only able to run their sterilization once a week. It's like basically your laundromat saying we're only open on Sunday now. And so we basically go there, we get all our scopes, and then we basically have to make it through the week with that. And so the one thing that we have to balance all these issues against is curtailing access for our patients to what are critical procedures.
Great answers there. And that's going to bring us into the conversation of the single-use sterile duodenoscope that we can get to in a moment. But there were many things that you talked about there that were excellent, and they brought to my attention something that we will talk about, surveillance systems for detecting infections in hospitals. They make me think about standards of care. And, of course, we can get to the issue of endoscope drying. But the guideline, when I compared the 2011 to the 2016 to the 2021 guideline that we're talking about today, I saw a couple issues that I wanted to discuss with you. The first one was the issue of sterilization, for example, of duodenoscopes in outbreak settings as opposed to non-outbreak settings. And this on its face makes a lot of sense to me. But then I considered, well, what if the facility didn't have the surveillance to detect those infections? So maybe using the model that the guideline used for sterile versus tap water, we kind of said, well, let's go with sterile water because it just seems to be better. And maybe there's a cost-effective issue to this, but I wondered if you could talk about kind of that issue where what if we're practicing sterilization for duodenoscopes in an outbreak setting, we're then going to do high-level disinfection, maybe double high-level disinfection, maybe single in a non-outbreak. But what are the possibilities we could actually be in the midst of a true outbreak, but because of inadequate or lacking surveillance, we weren't even aware of it? Then we could be disinfecting and not moving to sterilization of the duodenoscope, which the 2021 Multisociety Guidelines suggests we consider, because our systems can't detect and pick up on that. So what are your thoughts about the guideline then discriminating between non-outbreak and outbreak settings? That seems to me it's assuming that when an outbreak occurs, we can detect it. But that isn't always true, is it?
Great points. And I think so let me go back to, I think, why the guideline says what it does. And I'll preface my comments by saying my interest in this field was sort of a bit of trial by fire, which is that we had an outbreak in my institution. That's when I started learning about this. If you would have had this podcast with me 7 years ago, I would have said, well, just follow the manufacturer IFU. I didn't, that would have probably the end of our call.
I got to tell you, I've done a lot of education, Raman, and that's always been the punchline for reprocessors. Follow the IFU. And they're like,
right.
Yeah, okay.
Right.
That's how they immediately qualify whether or not the speaker knows their job or not.
Exactly. So, and that's kind of the way it was. And whatever I knew, I was like, well, look, if something didn't work, it was because, probably somebody didn't follow the rules, right? Or didn't do exactly. And I think we realize it's very complicated. And I think I'll just, before I kind of dig into that, people who do this work should not be viewed as like dishwashers. We often don't give them high pay. They're often not particularly given a lot of training, a lot of ongoing sort of resources.
And certification.
Exactly. And really, these people are, you should view them like airline mechanics, right? You're doing a complicated procedure and nobody says anything until something goes wrong. And so it's very important that we understand this is an important job. And the other issue is so much of what we say, and I kind of alluded to this earlier, is there's been very little research in this area, right? I mean, there's not a lot of studies if you take a look at it. And it's even hard even now. I would argue that since 2015, there's probably been more published research on the issue of endoscope device reprocessing than there has been in the history of endoscopes prior to that. I don't know if you'd agree with me, Larry. I know you would.
Absolutely. Well. I think you're spot on. I think the FDA has moved us in the direction and to the point of transitioning us to novel devices with disposable components or that are fully disposable. We can still be doing that under the classification of semi-critical. That doesn't require moving to critical. Again, it gets into the issue of how the hospital interprets this issue of what is feasible when sterilization is not feasible. Infeasibility of one hospital can be something that's practical in another. But it brings up another important point that the guideline introduced in terms of the non-outbreak versus outbreak setting. It introduced two other issues that I hadn't seen in guidelines before. The first one I'll talk about is risk assessment by the endoscopy center itself, and the other one is the immunosuppressed population. 30 years ago, 25 years ago, when I first got into reading this, it seemed to be a little bit of a taboo to say, and those were the HIV days, we'll treat one patient population that has the virus one way, we'll treat another patient population another. And we came out with the standard precautions that we would treat all patients similar. And it caught my attention then, two things that I saw in this guideline, and I may have misunderstood it, maybe you can clarify it for me, is one, we seem to, in some cases, move, for example, the sterile water versus the tap water, away from a standardized protocol where the guideline simply says, this is what you should do. Use sterile water. The guideline says to a hospital, perform your own risk assessment. The problem that can be is that different hospitals can be doing different risk assessments and hazard analysis that result in different practice. This brings in the topic of double standards of care. So if we do a standard practice and we consider a protocol that accounts for immunosuppressed patients, it seems to me, ideally we'd have one practice. We wouldn't have variable risk assessments. It would be all universal. And we wouldn't be sterilizing duodenoscopes, for example, because a patient who's upcoming in our procedure list that day is immunosuppressed. We would do one practice for the irrigation bottle. We would do one practice for the sterilization of the endoscopes. And we would do one practice, for example, drying and the alcohol rinse. And we can talk about that later. But maybe you have some thoughts then on this issue of separating the patient population into those who are otherwise healthy as opposed to those who might be immunosuppressed. And then that dictate the level of reprocessing we do for the duodenoscopes. That's not something I'm entirely comfortable with. That's something that the guidelines seem to discuss, not necessarily advocate. Your thoughts?
So the first issue was, I think you were talking about the use of ethylene oxide or sterilization in outbreak versus non-outbreak. That was just, Larry, based on the evidence that we had available to us. So, for example, there's not a lot of randomized controlled trials. There's, the disinfect study that was published by Schneider in gastroenterology a couple of years ago that looked at sort of this concept of double HLD versus single HLD versus ethylene oxide and sort of used sampling afterwards. And basically their conclusion was that they had roughly equal contamination rates afterwards. Now, there were some issues with that. I actually wrote the editorial for that study. And, they used single person sampling. They didn't separate between pathogenic versus not pathogenic. And so it was hard to say if the contamination they thought was environmental during the sampling process or truly residual on the scope. So the studies that we have to look at the quality of sterilization, particularly with duodenoscopes, have, as you know, all been done in a non-outbreak setting. And because those studies haven't shown a clear improvement, although granted, there's very little data, that's the reason for that recommendation. The recommendation in the outbreak setting has been many institutions, including my own, have incorporated the use of sterilization after an outbreak. And in fact, that, it's always hard to say, right? Because you do several things and you say, well, was it this? Was it that? Or was it this? And as you guys well know, I think the issue that we have here is that whenever you run into a problem, you identify every potential, could be this, could be, and then you try to attack as many as you can, but obviously all these things take time, effort, money, resources. And so obviously you'd love to be able to find the three biggest culprits, like these three things account for 95%, and then you'd love to tackle that. But I don't know that we have that level of data. That's the problem. And I think a lot of the recommendations you make, and you point out to some nuances, why don't you make a more forceful recommendation, or why don't you standardize it across the board for this or that? And the fact of the matter is that usually in medicine, when we do that, it's when we, sort of have this level one evidence, right? So we've got randomized trial data, multiple, and we even comment about the grades of evidence at the end of this document in the appendix, which is future data will be very unlikely to change the current recommendation. And, when you talk about things like the sterile water, Larry, or other things like that, we just don't really have much data, sometimes very little data at all in terms of studying these things to really be able to give an answer. It seems like a good idea, but at the same time, can you guarantee me if I do this that I will see a benefit in reduction in patient infections, et cetera? It's very hard to prove. Research in this area is very difficult, tracking these things. And as you mentioned, this kind of leads to the second part of your first question, I think, Larry, which is, how do you know that you're not in the middle of an outbreak and you may not have an issue? And it is true. It's very hard to detect these things. The MDROs, the reason we know about the MDROs is they're traceable, right? And if you take a look at some of the sites that have been able to identify this, they were doing research. And it was only because they were doing research and had some special molecular things could they trace the homology of these organisms. Go ahead.
And that's exactly to my point. They became above the radar in those settings, but they may not be detected in a facility that doesn't have adequate surveillance, kind of like the volume of a stereo is turned down too low to hear it. Well, in these bigger facilities, it's turned up, and then we do hear it. And then that caused me, as I was reading the recommendation about using sterilization in the outbreak but not the non-outbreak, it just caused me to have some of those thoughts. And then that's tying into, as we were talking about, risk assessment, because then the hospitals are making assessments as well as based on their surveillance detection systems as to what practice they should do. I ideally like a guideline to simply tell me what to do. I feel that too often in life I'm a sheep, and you just tell me what to do and I'll do it. And if you tell me to jump off the cliff, I might even end up doing that. Yeah. But I just like to know what to do. And I think that's really something that all of us
and I think you're honing in on something that's a reality of where we're at, which is that we don't know the best answer to give you necessarily right now. I mean, we think we do what makes sense and what's reasonable and practical, and we're always weighing these two issues. We don't want to limit access to patients, but at the same time we don't want to put them at risk for something we don't think is inadequately reprocessed, right? And I think but I think as more data comes out, if we clearly have, level one data showing that, hey, every study shows that this is what is the benefit, you'll see a definitive recommendation. And unfortunately,
we're on a continuum, right? We're on a continuum because you want to take it towards improving or process improvement, but without overwhelming evidence. You don't want to take a hardline stance. You want to create sort of this progression that you're trying to generate from the insight, and at the same time leave room for the data to either reinforce increasing and making things that may not be required over time.
Right. And, with regards to this issue of, do you do it one way for one group of people versus another? Certainly, we'd like to, if we had clear evidence that we should do something, I definitely agree. If we think something is the best, we should do that for everybody. I think it's clear. Right now, there's a level of uncertainty. So and also practicality in terms of we may not be able to do everything for everybody every time. So you say, okay, if you can't do it for everybody and you think it might be helpful, who would need it the most? And I think that's where that recommendation, you say, well, the person who could least tolerate one more hit, the immunosuppressed patient. So those are some of the reasons and rationale behind that. But I completely agree that if we can get clear evidence that something is the best thing to do, we should do that for everybody every time.
So I think that leads us into something that I know you have a great amount of passion for, and it seems like maybe it is the solution. We've talked about a lot of Achilles heels here. We've talked about a lot of things that can create almost a tension or a confusion. But if we were able to move from reusable to single-use duodenoscopes, then it seems that we remove this problem of immunosuppressed versus normal patients. We remove this problem of sterile water versus tap water. And then we remove the problem of something we can talk to if we have you back another time about the disinfected endoscope that has the sterile accessory put down the lumen. So it seems to me that maybe all three of those are all kind of addressed by our shifting to that single-use concept. So maybe you can talk about that a little bit and focus a little bit, if you can, on the issue of crossover. Can we see a world where, as you discuss now with us, your thoughts on the single-use duodenoscope, where we can have GI endoscopy units that are using only single-use devices, or because of crossover problems, and for our audience specifically, meaning we begin a procedure with a single-use, and maybe because of a maneuverability issue or some other characteristic of that single use, we're not able to complete it with the single-use duodenoscope, so we move to the traditional reusable duodenoscope. Will we see a world where the GI endoscopy unit can be using solely disposable duodenoscopes such that all these problems seem to resolve themselves? Or have I been remiss? Are not all the problems resolved, but most of the problems? I'm very interested in your thoughts on that.
Yeah, thank you. And this is an area of great interest of mine. And so, I think you're right. I mean, I think the concept of the single-use devices, it sort of takes your headaches away because it kind of really eliminates so many of the challenges that we've talked about from start to finish. The other thing I will tell you, as someone who's done research in this area, is that patients love the concept, right? So I think patient voice is going to matter. And, people like the idea that, hey, you mean no one's ever going to have this? And so really the issue becomes, I think, threefold. One, does it work? And will physicians adopt it? And is it safe? And will it provide comparable results? Obviously, if it doesn't work and there's no point having
they can't detect cancer. What's the point?
Exactly.
Right?
So if you can't do the device, and as you both well know, ERCP is the GI procedure associated with the greatest failure rate and the greatest rate of complications. Okay. So either you can't get it done technically or you have a complication. So we don't want to increase those rates and then we're just trading one for the other, right? So the second part, of course, is the money. Can you afford to do this? And I'm actually very pleased about certain aspects, which I'll talk about in a second. And the third is, we don't want to necessarily feel we're doing the environment a disservice, right? So we would like this to sort of be green and recyclable. And I can tell you that most of my experience has been, there are two now single-use devices, duodenoscopes on the market. I have been involved in the development and it was the PI for one of those. And the one that I was involved with, I know is going to be essentially a zero carbon footprint. The thing that I'm most pleased to tell you about, which is that normally when you introduce a technology, as you know, it's very hard to get anybody to pay for it. Why do we need the new thing? Are all things fine? And of course, in the era of COVID and healthcare and economics, everybody is buckling down. But the FDA gave these single-use devices as a category breakthrough technology status, which then led CMS to provide a pass-through payment.
This is fantastic.
Yeah, which means that you can actually get an additional payment on what you'd normally get. You're not just going to have to absorb this into what you were getting and turn a procedure that may have been somewhat profitable into a loss. And in our case, we're finding that the payment we're receiving is essentially full. And so it turns out that the most economical for Medicare outpatients now for us is to use a single device. And we've actually had much more rapid adoption of this in my institution than I would have ever predicted when this came on the market a year ago. So, the government is putting the money where their mouth is. They've said that they want this, as you said, Larry, what the FDA wanted. They wanted to try to move to this. And if you say, okay, if that's important to you, pay for it, because I think one of the things that we're in this is ERCP the cost is going to go up. Whatever we do, we're going to have to do more checks. We're going to have to, reinvent the devices. But we're going to have to train better our staff. All of these things are going to take time, effort, and money. But at the end of the day, if it's going to cost more, and if it's important to you, then we need as a society to fund that and say that it is important. And of course, we will save on the back end in terms of infections and all the other issues that are related to that. I think I'll close by saying that, we're in a unique time where, we've identified an issue, and it took a while to get everyone to acknowledge it was an issue, but I think we've reached that point now. And I think everyone's trying to figure out what the best solution is. There's a ton of different technologies and new devices and products, all of which cost money. And I think institutions are taking sort of a paralysis by analysis. You don't want to buy the Betamax when everybody goes VHS, right? And I think you're like, well, what's the right thing to do? Is it going to be single? My personal feeling in closing is that, the data that we have suggests that well over 90 to 95% of these cases can be done successfully without crossover by experienced endoscopists. Now, we're going to need to see if that translates to people who aren't academic experts and don't do necessarily the toughest cases. So time will tell, but I do think this will gain adoption. I think we're seeing signs of it already. We're seeing payment. I know patients are interested. And I believe that single-use devices will play a major role. And I think with iteration improvements, you can also iterate faster. It's not like now a car that gets a new model every 5 years. You can iterate very quick. And so you may see left-handed versions. You may see...
Because you don't have the capital investment that needs to be drawn out over a period of time.
Right.
It's interesting, but what you're saying is that not only is this decision, sort of needs to be weighed, but it needs to be weighed by parties that aren't always as heavily involved in that kind of a conversation, which is supply chain and revenue cycle.
Absolutely. Yeah. So I think people are trying to do the finances and saying, hey, what's the best way? And I think, ironically, I would have never predicted this a year ago, but single-use devices turn out, at least for Medicare outpatients, to be the most economical option because of the pass-through payment. So I think you'll see greater adoption of this, and I think it's a good thing. But I do know, going back to wrap up, Larry, on sterilization, I know that the major endoscope manufacturers are all working on low-temperature sterilization, I think. So we're going to have to see if they can come up with a low-temperature sterilization option that's feasible and economical. I don't think anyone's against sterilization. I think it's just the practicality of it. Do we have a way to do it that makes sense? And, hopefully in a few years that we're going to be able to say yes to that.
Fantastic. Wow, what a great interview. What great information, Dr. Raman.
Great. You did an amazing job. And I want to say thank you for all your work on the Multisociety Guidelines as well. And I know that's an ongoing project.
Yes.
So keep up the good work. Thank you for joining us today and really appreciated having you on.
And thank you for the care that comes out that you have for the patients who are coming to you to be helped. It's really great to know there are people like you that take care of us and really look out for our interests.
Thank you so much for the kind words. Really enjoyed it, Larry and Justin, and happy to do it again sometime.
That was Dr. Raman Muthusamy, professor of clinical medicine at the David Geffen School of Medicine at UCLA, and he is also the medical director of endoscopy for the UCLA health system. And obviously, Larry, very involved in what is going on to shape gastrointestinal procedures across the country, and reprocessing, as I mentioned, such a an area of great interest to me. And trying to drive that industry forward. I do a sister podcast of ours called Beyond Clean that covers sterile processing and reprocessors in the industry. And our chief medical officer of Beyond Clean has done a lot of studies about what Raman was talking about, which is how are these people trained? What are the requirements of the job? How can we raise the level of awareness? And so this topic is very akin to something that I've invested many years in of my professional career already after having left nursing and have moved into more of an entrepreneurial and sales career. But the thing that I also learned as I left this clinical world was a lot about supply chain. And even now, I'm only getting exposed to finance and understanding rev cycle because I came from this other side of the spectrum. And something that we talked about just at the very, very end is just how heavily involved, but somewhat behind the scenes, the supply chain and the finance and revenue cycle folks at hospitals are in this conversation. I know they're always involved in the purchase of new medical devices and looking for cost savings initiatives, but in this case, I almost feel like they have a very direct influence over the direction of what are the next steps at this point when we're talking about sterilization, single use, and high-level disinfection.
Yes, as well as the accountants that are determining whether Medicare reimburses for these types of procedures or whether the facility itself has to put this money out in order to really address its patients' needs and desires to have a single-use product. So that's really, really a big step forward. I think also what I learned in this discussion with Dr. Raman is that as many questions as we're answering, it seems like for each question we answered, there are 2 new questions that arise. So this is a fascinating field. We're going to do our best in this podcast as well to answer as many questions as we can so we can maybe get a convergence on this and come up with some real solutions. We have many, many solutions now, but we have these questions we talked about. Can a different type of scope be used in an outbreak setting compared to a non-outbreak setting? That's specifically meaning a disinfected endoscope maybe for non-outbreak, a sterilized endoscope for an outbreak setting. And we talked about risk assessment and how maybe one GI endoscopy unit does a risk assessment and says we really have to go with sterile water for the irrigation. And another facility may say, no, we don't have to go with sterile. We can go with tap water. And then we kind of touched on, and maybe we'll address this in future podcasts, about the standards of care. This is something that for years, nurses, and I appreciate very much, are very sensitive to. They want their patients all to receive the same standard of care. And I just want to make sure in this whole discussion of single use versus reusable, of sterilization versus high-level disinfection, of critical versus semi-critical, we don't lose sight of the fact that we can be approaching a slippery slope where different patients, depending on their immunostatus, for example, or depending on maybe they're a carrier of a superbug, they may be treated or viewed differently. And this is something that is a very slippery slope and something that we want to try to be aware of and to mitigate so that all patients receive the same ideal care that a physician like Dr. Raman, who showed his compassion and his passion for all this, will certainly assure.
Yeah, absolutely. This is a great interview. I am sure that we will have Dr. Muthusamy on again in the future if he'll have us. That's going to do it for this week's show. As a reminder, you can help support us by subscribing to Transmission Control on iTunes, Stitcher, Google Podcasts, Amazon, and Spotify. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Larry and myself, thank you for listening to this week's episode of Transmission Control.